My name is Dr. Jay Joshi. I am a double board certified anesthesiologist and interventional pain physician, and I practice in the Chicago suburbs. I have been treating CRPS patients and chronic pain patients for about 15 years now, and a lot of people have asked me, hey, how did you decide to become a pain doctor? Well, I guess the definition of pain doctor is probably for another video, but I decided to go into pain management because at a pretty early age, I think I was really curious about the human body, like a lot of other physicians, and I was really disappointed that I didn't understand my own body and I wasn't able to help people. And so I had that deep interest in sort of helping people and making a difference at a young age. So I applied to medical school while I was in high school and was fortunate enough to get into an accelerated medical program when I was in high school. And obviously at that time, not really knowing what I wanted to do, I just knew I wanted to do something where I have an impact in people's lives, a dramatic impact in people's lives quickly. And it was somewhere in college and maybe med school, but somewhere along there, where I was exposed to interventional pain management. I saw people coming in who weren't able to walk, and they were leaving the office walking, after some type of procedure. And I was like, this is like voodoo, right? This is magic. How in the world is this happening? It's absolutely fascinating. And I think at that point I knew, I'm like, listen, this is something where you're making an impact right away, and you're changing not only their physical state, but their emotional state. I mean, what more can you ask for as a physician? Like, you're literally changing their whole entire life in a matter of minutes. So that's what attracted me to interventional pain management. And then people ask me, okay, how did you get involved with CRPS? I mean, how did you start seeing those patients? What was the level of interest? I don't really know when that solitary moment happened. I think what happened is, you ended up seeing your first CRPS patients, which I don't remember because it's not like you sort of, write it down. You just see whoever's at your door and whoever's in your office, and you see them. And I think it was a challenge. I've heard this story so many times with many other CRPS patients where I don't think I was ever really the first person that a CRPS patient has seen. In many cases, they've seen multiple other physicians. I think our record is 60 physicians before the patient actually saw me. And I think there was no different in this case where patients seeing me, seeing many other physicians, failed many other treatments, and now the challenge had fallen squarely at my feet, where I have to now figure out how am I going to help this patient because they're at really pretty close to the end of their rope, and what can we do? And in some cases, I had to create ideas and protocols to try to help that patient. My first ketamine infusion, for example, was in 2007 when virtually nobody around the country, especially anesthesia interventional pain physicians, I think there were only maybe a couple other physicians, let's just say maybe maximum of 5, double board certified anesthesia interventional pain physicians that were doing it at that time. So I literally had to create my own protocols and create my own theories and philosophies on how it should be done. And I think it just snowballed after that. It's like, wow, once you see a really awesome success, and then someone else comes to the door and you're able to replicate it, then all of a sudden you're like, I think I'm onto something. And from a self-satisfaction standpoint, when you can change someone's life that is unfortunately headed in a direction that's really negative and completely transform it and have it head toward an incredibly positive direction, the self-satisfaction that one derives from that is absolutely undescribable. I think if we had to put in scientific terms, the dopamine release that I got from that was probably the biggest high that you could ever imagine. And you want to replicate that. And so it's been really exciting working with CRPS patients for close to 15 years now. And I won't say that we're 100% successful 100% of the time, but I will say that one thing, we give it 110% effort. And with that 110% effort, you're able to at least make a small impact, if not an incredibly large impact. And so that in itself becomes self-satisfying. But there are a few things that I want to discuss today. We want to go over some patient stories. We also want to go over some of the sort of background on CRPS, some knowledge and some facts around CRPS. and really some real world information that you can take right now as a patient or as a physician or a provider, incorporate into your practice, and maybe some things that might help you better take care of those patients. So again, you can see some of those exciting outcomes that I've seen and provide patients hope and provide them relief. Chronic pain. It's a term that is thrown around quite a bit and getting more and more attention in the media because of a lot of different reasons. But do we really understand chronic pain as a society and as a medical profession? Some say no. And within chronic pain, we have multiple diseases that are not well understood by even medical professionals, but also by society in general. One of those diseases is something called CRPS, or Complex Regional Pain Syndrome. It used to be called RSD back in the day, or reflex sympathetic dystrophy. And it's not new. It was first described, at least we think, in the Western world during the Civil War, but when you really trail it back even farther than that, you can find scientists in Europe, which are still the Western world, describing elements of the process of CRPS back in the 1600s. So this is not something that was just made up yesterday. It's not something that's really necessarily new. It might be new to you. It might be new to a group of physicians or a group of nurses or a group of healthcare providers or, quite frankly, even an insurance company, but it's not something new. I can tell you just from a personal standpoint, I run into physicians and nurse practitioners and PAs, nurses, members of the healthcare system, but insurance companies who have absolutely no clue what CRPS is. We're trying to get approval for a patient just a few weeks ago, and the patient has CRPS, and we were trying to get some approvals for procedures. And the discussion revolved around the FDA, and the insurance company literally didn't know what the FDA was. So there's a lot of primitiveness in not only CRPS, but also chronic pain and a lot of different treatments. Our goal today is to try to explain this disease, explain some of the aspects of this disease, and hopefully get you more familiar with this disease process, some of the mechanisms of action, some of the treatment options, but also how does it affect the patient, and really trying to drive home that message that this is a real disease and these patients are real people who are looking for treatment. And when we don't diagnose them correctly and when we don't treat them correctly, catastrophic problems can happen. And it's our goal to try to avoid those catastrophic problems for those patients. So I've been in private practice for about 15 years. And to me, that's not a very long time. Some people feel it's a long time. I think a lot of people still think that I'm pretty young and just starting out, I definitely don't feel that way. But 15 years is not that long in the sense that from a training standpoint, which was really in the early 2000s, I really feel that diseases like CRPS should have been well understood and should have been well taught. Again, this is not a new disease. So I was really surprised, looking back and now being one of the experts in the field and really sort of treating patients from all over the world with CRPS and looking back at the training that I had and looking back at the mindsets of my attending physicians who were supposedly experts, I'm shocked at their lack of real knowledge and, quite frankly, compassion. When it comes to CRPS, I don't think I was taught correctly, and I don't think that is any different than the rest of the medical world, and it's really disappointing. We learned about CRPS in and of the disease of being a rare disease and something that we may never see. Maybe we'll see one or two patients in our career. And that's simply not the case. Now I see multiple patients every single day with CRPS. So as far as I'm concerned, it's not a rare disease. I also see spectrums of CRPS, something that I don't think has been well described in the literature at all. When I was in medical school, I am pretty sure if I had any exposure to CRPS, which at that time was really called RSD, I'm pretty sure that it was just a blip in my overall medical education, and probably one question on some obscure examination. And we treated it like that. It was one of those things that we were like, well, we're learning for this test and we'll probably never see it again. And I think that's how most of medical students and most of practicing physicians look at this. And so when they see a patient with CRPS, now, what do they think of that patient? Well, I'll tell you what we've seen. This is real. This is real. These are stories that actually happened. Many of our patients say that their physicians didn't believe them. Some of them will say, well, they believed me, but they didn't know what to make of it. Others have told the patients, well, it's all in your head, with the intention of saying that you're nuts or you're making it up, not with the intention of actually saying it's in your head mechanistically from a mechanism of action of central sensitization, so kind of missing the boat there. And a lot of those patients thus were either misdiagnosed or mistreated, which in some ways is even worse than misdiagnoses, because when you're sort of saying, yes, you have CRPS and you're nuts and, deal with it. Probably one of the worst things you could say to a patient, deal with it, suck it up. That's not your job as a physician. It's like going to a restaurant and then they're saying, hey, I'm hungry, I'd like to get fed. And the waiter says, well, deal with it. That's not how you treat a patient, right? So I think there's a epidemic of misdiagnoses and probably a bigger epidemic of mistreatment and misunderstanding of patients with CRPS. And it really goes back again down to the fundamental educational process that we have right now. We have a system in place that simply doesn't look at mechanisms of action with these complex pain diseases and really chronic pain in general back in medical school, back in residency. Now we're dealing with this opioid epidemic, right? But if you dialed into that, rarely will you actually hear the nuances of this epidemic. What you hear in the media is that if you have chronic pain and you're on opioids, you must be a drug addict, and that's simply not the case. When you look at the deaths that have come with opioids, people don't really delve into the details of where those deaths are coming from. They don't talk about the fact that the majority of those deaths are from counterfeit medications or from patients who have gone to illicits, or the fact that many of these people aren't even patients to begin with, or the fact that some of these patients have now gone to counterfeits or illicits because they weren't able to get the right care or diagnoses from the physicians that they entrusted their lives to, or these big hospital systems that they entrusted their lives to. So medical education is incredibly important. And again, when we do these kind of videos and when we do these types of educational programs, that's really the message we want to get across. Number one, thank you for even watching, because it means that you have an open mind. It means that you want to learn. It means that you want to make a difference and you want to help people and you want to do it the right way. So thank you for the people who are actually watching. Now, the people who aren't watching, well, whoever's watching, get those people to watch, get those people to learn. Get them to actually look at the internet. Don't be scared of the internet. I hear this also a lot. Physicians will tell patients, oh, don't look on the internet because you don't want to be exposed to bad information. That's absolutely true, but you also want to be exposed to good information. So I think it's our job as physicians and as healthcare providers to make sure that if we're going to tell the patients, to look at the internet, and quite frankly, they're going to look. Look, they're going to look whether you want them to or not. So maybe it's your duty to direct them to the right places and the right source of information. Let them learn the correct facts. And you should too, right? Learn the correct facts, get the correct information from not just websites, but publications. Remember, publications can be skewed in one direction or the other. So it's our job to be able to read between the lines and to be able to filter good publications from bad publications. Publications that are wrought with bias or with inappropriate conclusions, to publications that are accurate and describe mechanisms of action and have some type of insight into how a disease evolves. And when we do that, then we know what the facts are from what the fiction really is.
So let's go on. Now we're
One of the challenges I found as practicing as a pain management physician has been misdiagnoses and underdiagnoses as well as late diagnoses. So we have patients who may have had a chronic pain condition for a while, or patients who may have had a surgery, or patients who have had an acute pain problem that wasn't intervened in time, wasn't managed correctly, and then it became a chronic pain condition. and now it's sort of, locked in and it becomes much harder to treat. Now we can see that with examples of back pain, examples of neck pain, headaches, migraines, other nerve problems. But it's especially true and especially important in cases of central sensitization. Now, central sensitization is a condition where the central nervous system has become hyperinflamed or hyperactive. We call it hyperalgesia. One of those conditions under central sensitization is CRPS. So with patients who have CRPS, if they're not diagnosed correctly or they're not diagnosed early, the problem becomes even more dramatic. It becomes even more cemented in. There's a sense of permanency, both psychologically as well as physically, when patients are not diagnosed early enough. So early diagnosis is important. Now, that doesn't mean that if you've been diagnosed or if you've had CRPS for years, don't get me wrong, that doesn't mean that there's no hope. That doesn't mean that we can't put this in remission. It just means that it might become a little harder. So that's why as a patient, as a physician, early diagnosis is important. I guess that brings us up to the next question. Okay, how do you diagnose someone with CRPS? If you have a heart problem, we can do an EKG. If you have diabetes, we can do some blood tests, right? Even cancer, there are tests that we can do to identify if you have cancer, if you have high blood pressure, if you have diabetes, or a lot of these common problems. Well, unfortunately, there's really no blood test for any type of chronic pain, and there's no blood test for CRPS. Of course, we can do blood tests and they can say, oh, I see some inflammation. There are some factors that we can test for to see that. But that's not specific and it's not really accurate. And of course, you're going to have some inflammatory agents that are going to be positive in certain disease states. That's why you're going to the physician. That's why the patients are coming to us. They're not feeling well. So getting a blood test that says either nothing or says something to kind of prove that is kind of irrelevant. So we do have to focus on the history, on the physical examination, and we have to actually listen to the patient. Wow, what a novel thought, You actually have to listen to the story. But if you listen to the story and you actually give some extra time and effort in listening to the story will almost tell you exactly what's going on. When you can really understand that story and then mechanistically get that story into some type of scientific effect, right? Understand what is actually happening neurophysiologically, what's happening chemically, what's happening from a receptor standpoint, what's happening from a nerve standpoint, a tissue standpoint. Put that story into science. Then you start understanding what kind of disease is taking place. Now with CRPS, it is a central process, and that is so incredibly important to understand. Forever, I can remember even back in training, my attendings kept saying it's a peripheral disease. And it's like, no, it's not. I remember having these discussions with them. And of course, them thinking they're 30, 40 years older, they thought they knew everything. Well, guess what? 30, 40 years older, what that meant is that they studied back in the 70s with books that were made in the 50s. Okay, they didn't have a clue as to the mechanism, but they also didn't have an open mind into trying to understand, maybe some of these newer mechanisms and newer thoughts. With a lot of data coming out, especially in the 2000s, on functional MRIs, and data coming out on actual central nervous system changes that occur with chronic pain. And these guys refused to listen to that, and they just wanted to keep their old thoughts that they learned back in the 50s. It is a central process, okay? It's a central nervous system process that has peripheral manifestations. And some of those peripheral manifestations have been well described with something called the Budapest criteria. So this is a set of criteria that came out approximately 15 years ago or so. And this criteria was really meant to help physicians, healthcare providers, patients understand if they have CRPS. So if patients met these criteria, then they have a very high chance of CRPS. And that data, or those criteria, were really helpful. It really helped us sort of objectify this disease state that really doesn't have a blood test, or really any test, right? There are some, you can do functional MRIs and they can kind of fingerprint CRPS and other central sensitization conditions. But functional MRIs are really very academic in the sense that they're not widely available and insurances don't really pay for them. So no one really does those. So this criteria really helped us objectify CRPS and document CRPS and prove that this patient has CRPS. But I'll tell you what, there's a problem with that criteria. The problem is that everyone now got shoehorned into you either met 100% of the Budapest criteria and you had CRPS because you met 100% of the criteria, or you didn't meet the criteria. So what happens to all of those patients, and quite frankly, the majority of patients who actually have CRPS and elements of CRPS on that spectrum of CRPS, who now don't meet all the Budapest criteria? What happens to those patients? I'll tell you exactly what happens to those patients. They get left behind. And we've seen a ton of those type of patients in our practice, where they absolutely have central sensitization, they absolutely have CRPS, but they didn't meet 100% of that Budapest criteria, or even worse, they actually were starting to see relief from some of their symptoms because of all the interventions that myself and other team members and other physicians were able to offer those patients. And because they met some of those criteria, they no longer had CRPS, but in fact they did. And we've seen insurance companies leave them behind and abandon them. We've seen other healthcare providers and other physicians abandon them because they say, well, you don't meet these criteria. So that's been one of the challenges now with the Budapest criteria is you're actually seeing some people who are getting benefit, but you're seeing a lot of people left behind who don't necessarily meet that criteria. We'll refer you to the Budapest criteria slide here. Some of the key points I want to make sure that you understand from the Budapest criteria is, number one, it says that patients must have pain that's disproportionate to the inciting event or to the injury. So that's one of the biggest hallmarks, and really we do see that with CRPS across the board, 100% of the time, right? Pain that's out of proportion with the degree of the injury. But in addition to that, patients must show at least one of the following signs. Number one, they must have sensory hyperesthesia. So that means that when you touch them, light sensory touch, their pain is again out of proportion with what their pain should be with that touch. And in many situations, they shouldn't have any pain with that touch. When they're supposed to have no pain with that touch and they have pain, that's called allodynia. Number two, the patients must have some type of vasomotor changes. So that includes vascular changes, decreased blood flow, which is hallmarked with temperature changes and or color changes. So you'll see an extremity that might look red or blue or purple, or you might see an extremity that has a large temperature difference, at least 1 degree Celsius in temperature difference. Now, you might also see what we call pseudomotor changes. So that might be things like sweating, okay, or edema, where they're getting more swelling or areas of their body are moist or sweating more. And then finally, you may see motor changes. So decreased motor function, weakness, tremors, dystonia. You may see things like hair, skin, or nails changing, hair falling out or hair not growing, skin looking a lot more scaly, not really looking as healthy. I've seen even patients where their nails are falling out. Well, again, here's where some of that criteria becomes a little more complex. What about those patients who have those pain changes, but a lot of their symptoms are improving in terms of their visual symptoms are improving? Do they still have CRPS? That's been one challenge that we've had. And the other challenge is what happens when you actually have CRPS that doesn't live in your extremities? And this is very real. We see this. We've seen CRPS, probably the most common area we see it, that isn't well described and absolutely defies the Budapest criteria is the GI system. I can't tell you how many times we've seen gastroparesis misdiagnosed. So people will be diagnosed with gastroparesis where in fact they actually have hypersensitization of their GI system. It's a spectrum of CRPS. Obviously, I'm not going to be able to see a color change. I'm not going to be able to see a temperature change. I'm not going to be able to see a tremor of the tummy, right? I'm not going to be able to see hair and nail fall out in the tummy because last time I checked, that didn't exist in the tummy. So how how do we then reconcile the Budapest criteria with CRPS that doesn't live in the leg or in the arm or in the upper extremity or lower extremity? And this is where we see that criteria sort of break down. And this is where we see our ability to take care of patients start falling apart. And this is where we see patients who have misdiagnoses, unnecessary surgeries, diets that actually harm them more than they help them, right? And then we see all these fads and all these various other things, because patients are trying to get better, but they don't know where to go, because again they've been misdiagnosed. So it's important to try to appreciate the Budapest criteria for what they are and what they were meant to be for certain locations of CRPS. But it's also important to understand the fundamental mechanism of action of CRPS and understand that when that mechanism is in play, how does that affect different body parts? Because it's going to affect different body parts differently. And once you understand that, then you're able to potentially diagnose patients maybe more accurately or more quickly. We've talked about the importance of diagnosis. I mean, that goes without saying. I think every healthcare professional knows diagnosis is key, right? You go to the car mechanic's shop, and if he doesn't diagnose your car problem correctly, right, bad things happen. So same thing with the human body. I mean, that's pretty basic. But we've talked about the fact that we need to diagnose quickly. We've talked about some criteria that have been used for diagnosis. We've talked about the fact that we need to go even above and beyond some of those criteria when we really want to delve into some complicated CRPS cases. Let's talk about who gets CRPS. What's the backstory behind the disease? Again, CRPS is part of this cluster of pain called central sensitization. Just to go over the 4 clusters of pain, okay, so we are all on the same page. Cluster number 1, we've all heard of neuropathic pain or nerve pain. Cluster number 2, we've heard of nociceptive pain, things like when your bone is hurting, or organ pain. Cluster number 3, inflammatory pain, okay, so things like arthritis or other types of inflammation. Then cluster number 4 is central sensitization, probably the least understood or the least aware of all the clusters. And central sensitization is the central nervous system. The central nervous system is not firing correctly. It's either misperceiving or misinterpreting signals. Now, why is it doing that? Well, it's doing that because it's become sensitized. It's become sensitized to some type of injury or some type of event or some type of memory. But something has caused the brain to think that a problem is persisting, to think that an injury is persisting, to think that maybe the leg or the tummy or the arm or whatever part of the body is affected is undergoing an ongoing traumatic event, and it's trying to protect it from that event. And that's a fundamental disease process, obviously in very, very easy terms. So the brain is literally thinking that that there's a problem. So that's where you're going to see changes in the motor system. You're going to see changes in the vascular system. You're going to see changes in the way that it's trying to protect, let's just say, the extremity through sweating or through hair changes, through vascular changes. And for some reason, and we're not quite sure why, there are some hypotheses out there, but for some reason it affects women far more than men. There have been hypotheses as to why. They've been, maybe it's genetic, maybe it's the way the neural system is set up for some reason in women more than men. Maybe it's related to hormones, maybe it's related to the way different genders handle stresses. We're not really sure, but even if it's related to all those things, why? The question becomes why. And we're not really sure. But there's absolutely no doubt that it affects women far more than men. I can say, at least in our practice, we're seeing probably close to almost a 10-to-1 ratio, women versus men. Some of the published data out there varies, but every single piece of data out there shows a dramatically higher rate of women versus men. But you know what? We're seeing that with other diseases as well. So fibromyalgia is a form of central sensitization. And fibromyalgia very much could be looked at similar to CRPS. A lot of people will say, hey, they kind of look similar to each other. And you know what? They are very similar to each other. Fibromyalgia is really this chronic, widespread neuropathic pain hallmarked with central hypersensitization and central hypersensitivity. So your whole body, feels hypersensitive, but you don't really have some of the hallmarks that you see with CRPS. And that affects women a lot more than men. The published data on that is very close to that 9-to-1 ratio, women versus men. But another disease that is a central pain condition is something called PTSD, post-traumatic stress disorder. I had many publications looking at the mechanism of post-traumatic stress disorder and some procedures that have helped with post-traumatic stress disorder. So it's a condition that I've worked on for many, many years and seen patients from all over the place with PTSD. And PTSD and CRPS are very similar centrally. Peripherally, they manifest a little differently. But with PTSD, we see women, we see men with PTSD. A lot of people think PTSD is a man's condition, but mainly because a lot of PTSD exists with the military. We associate PTSD with the military. But you know what? I see a lot of PTSD in women. We've seen a lot of patients who have been, abused, harassed, molested, beaten, or a variety of other things that have affected them throughout their life. And it's created this hypersensitization in their brain. And we've seen patients who have PTSD end up developing CRPS because their brain has become already sensitized. And then the patients experience some type of injury. And that injury could be as innocuous as an IV start. I've actually seen CRPS because of an IV start. We've seen CRPS because of surgery. We've seen CRPS because of some type of fracture. We've seen CRPS because of some type of minor injury, like an ankle sprain, right, or even stubbing a toe. I've seen CRPS from eye surgery, LASIK surgery, right, something that most people have never heard of. But if you actually start looking it up, there are many case reports, and in fact even groups, right, little Facebook groups or closed groups where patients are saying, "Hey, I developed CRPS after LASIK surgery." So it can happen without any previous sensitization, but when patients have become sensitized already, the chance of it developing becomes substantially higher. So what's the take-home point there? Take-home point, obviously, is understand the mechanism, understand the disease, understand that it affects women more than men, but also the big take-home point is when patients have had central sensitization, they've already been sensitized because of some type of event or whatever, really pay close attention to those patients. Pay especially close attention if they're undergoing a surgery, because they are absolutely more predisposed to potentially developing CRPS after that surgery. And those patients are going to have to be pre-medicated in multiple different ways to try to lower the sensitization that the brain will feel and lower the chance of progression to CRPS. So you have a patient and they've either been diagnosed with CRPS or you've diagnosed them with CRPS, and thank you very much for doing that, especially if it's the right diagnosis. I'm glad that you found it. What do you do at that point? So you have this diagnosis, and when patients read about CRPS online, I can tell you that they'll come back and they'll be devastated. It's in some ways as bad as giving someone a cancer diagnosis. They really feel that this is it. Like their life is done, and it's not. Okay, so let me make sure that's clear. It's not. There are many options available, and options that honestly could potentially reverse or put CRPS in remission. Okay, we've seen that, and we're not the only ones who've seen that. Other people have seen that as well. So it's possible, but it definitely takes a commitment and it takes effort, and it takes understanding of knowing what options are out there. So obviously, option number one, the first thing you're going to do is start with some of the most basic treatment options, right? Things that you would probably do anyway. Things like maybe for pain, you would look at acetaminophen, or you look at NSAIDs, right? Maybe you would look at heat or ice. But remember, sometimes that's incredibly hard because patients can't tolerate anything on their skin. Like, you'll have patients coming in, say, listen, I don't wear clothes, I don't wear socks, I don't wear anything because I can't, it's so hypersensitive. So those kind of things may not actually work. Topicals may not work. In some cases, topicals will work. Remember, I talked about a spectrum, right? So we have patients who are very hypersensitive, but they can actually tolerate topicals, and in those cases, topicals may actually be helpful. But moving on, Beyond those, there are other medications that we can use, the nerve pain type of medications, the muscle relaxant type of medications. I'm not going to mention any brands or any molecules by name because that's not the purpose of this video. So you're going to see that I'm being pretty broad in general. Even opioid medications, right? While they don't help with CRPS mechanistically, because again, CRPS is a central pain condition, it's a neuropathically active central pain condition that involves neuroplastic changes. Opioids are working on mu receptors. Okay, there's totally different mechanisms of action. But patients who have CRPS are going to have peripheral manifestations, and they're going to have pain. And even though the opioid might not help with the CRPS, it might help quell some of that pain, especially when you have really bad flare-ups of pain. I am not an advocate of using opioids for everyone. I'm definitely not an advocate of high-dose opioid medications. In fact, I was the first physician, I'm pretty sure, in the country to predict the OxyContin epidemic in 1999. Before I was even a physician, I was the first physician or first to-be physician to work at the World Health Organization's Department of Substance Abuse, because I felt so passionate about this impending problem that took everyone else 15 years to figure out. While that's being said, we don't want the perversion of the opioid epidemic, and the perversion of that is, hey, they're all bad. No, look, certain patients need certain treatments. It's when we don't know how to provide the right treatment or the right molecule for that patient or the right technology for that patient, that's when we run into problems. Very similar to another modality that's becoming popular, cannabis. Many years ago, I was in the news media in a pretty well-known outlet, talking about how cannabis can absolutely be helpful, way before it was legalized medically or recreationally. But I also said at that time, we have to be careful how we utilize that treatment, because if we're not careful, we're going to have a lot of people having side effects, and that's really the key here. Side effects with opioids, side effects with cannabis, side effects with muscle relaxants or nerve pain medications or with any sort of modality. We have to understand those. We have to know when to do things properly and when not to do things. But opioids can be an option. There are certain molecules, again, I won't mention them here, but certain molecules that actually have dual mechanisms of action where they can work on the mu receptor, but they can also work on nerves and nerve receptors and NMDA receptors, which is one of the key receptors that we see with central sensitization and CRPS. Physical therapy is a wonderful modality. Again, you got to have someone who understands CRPS and they understand that, hey, we're not just trying to strengthen a muscle, we're actually trying to reverse a process where the brain thinks that the extremity is disconnected, or the extremity is not working, or the extremity is undergoing an active injury. So they need to understand how to do physical therapy where they involve both extremities. Mirror box therapy is another option. Aqua therapy is another option. Some patients, again, are not able to do it because they're not able to tolerate the water. Some patients can do it. But therapy of multiple different types is important. Mental therapy, okay, not because the patient is nuts, okay, but because we have to address the fact that centrally what is going on. We're seeing chemical changes, we're seeing neuroplastic changes, we're seeing nerve connections that are forming, that are aberrant formations. And what we want to do is sort of redirect those aberrant formations into the correct sort of nerve connections. The connections that have always been there saying everything's normal. And so mental therapy that can occur in many different types. I mean, it could be just talk therapy, it can be cognitive behavioral therapy, it can be biofeedback. We've used things like brain mapping, even some apps that are out now are really trying to focus on patients trying to be able to sort of understand the disease process and trying to, almost create this positive energy or this positive thought process that's going to hopefully get them to switch that switch back to the way their brain used to perceive problems and used to perceive pain from the way that the brain is now perceiving it. And let me take this moment to point out that perception of pain is not a voluntary perception of pain. This is how the brain is evolving. Your whole personality is changing. Your whole perception of the world is changing. You are literally becoming a different person without wanting to become a different person. This is not a conscious process, it's an unconscious process. However, through conscious processes, we can potentially, hopefully, change the direction of that ship and right it. There are other treatment options that are available. Interventionally, there's something called a lumbar sympathetic block or cervical sympathetic block, also called a stellate ganglion block. And those are used to try to reset the sympathetic nervous system and try to disrupt this sort of hamster wheel. We've used spinal cord stimulators, a way of overriding painful signals with non-painful signals. They work, but obviously if you look online, there are a lot of failures too. And those failures can be for many reasons. Again, assuming everything was done correctly, some of those failures exist simply because of the fundamental mechanism of action. You know, we have a central pain condition that's causing peripheral symptoms. And those peripheral symptoms can actually cause peripheral damage, which then tells the brain again, hey, we've got a problem, and then, you know, the sort of cycle continues. The spinal cord stimulators are trying to break that cycle. But sometimes that cycle doesn't necessarily break, and we see a failure with those devices. Ketamine infusions have been remarkably effective in our practice in breaking that cycle of pain. Why? Because ketamine is a NMDA receptor antagonist. What that means is it's binding to that NMDA receptor and antagonizing it or blocking it. When we can use the right dose for the right patient, along with a lot of other adjunctive medications, okay, kind of creating that perfect soup for that patient, the perfect amount of different things that live in harmony, that will work just right for that patient's brain, we are actually seeing a reversal of those symptoms or a remission of those symptoms on the spot. I mean, patients are leaving saying, oh my gosh, I can actually shake your hand, I can touch my leg, I can eat food, okay? Important small steps that are absolutely meaningful and life-changing for patients. Now, it doesn't last forever. None of these things will last forever in and of themselves. You know, if you take a medication, you don't reverse the process. If you do physical therapy, you don't reverse the process. If you do a stimulator or an injection or even infusion, you're not going to necessarily reverse the process forever. Why? Because that neural circuitry has changed. And for that switch to flip back and forth, you know, it doesn't necessarily take much. It could be any type of trigger. It could be a trigger of a memory that's already there, and those memories are what are sort of causing the brain to kind of spool up or wind up. Or it could be a new trigger, okay? This is what's complex about the whole complex, you know, CRPS that we describe. Other treatments have been described as well. Things like IVIG have been described, and that's helpful with the autoimmune secondary effect that we see with CRPS. There are some trials using bisphosphonates, and they've been helpful when we start seeing bone-related side effects, which we see with CRPS. Other options include things like lidocaine infusions, lidocaine, you know, trying to help with the peripheral nervous system, peripheral nerves that have been affected. And there's some other things on the horizon, too, that we are seeing. Currently, we also see electrical therapy, external electrical therapy through a variety of different branded and non-branded options. We're seeing microcurrent therapy as well. Hypnosis has been used. You know, if you look at how all of those modalities are trying to help, again, they're trying to help the electrical system. So try to look at it more from an Eastern medicine standpoint, you know, chi, flow, energy flow. We're trying to get everything to sort of be in harmony with each other again. And really, honestly, that's not much different than what we're doing from the Western side. Trying to get everything in harmony. We're trying to get this wind up, this spool up, this hamster wheel to stop. And so hopefully it will spool back up. It'll reboot the normal way and not the abnormal way. So as we wrap up this wonderful video, there's a few things that I think should be probably some of the most important take-home messages. And number one is always remember, one size fits one. Okay, there's no such thing in pain management. All of pain management, I don't care if it's, you know, CRPS or any type of chronic pain, there is no one algorithm. And I think that's probably the biggest problem, right? In cardiology, we have algorithms, and endocrinology, we have algorithms, right? there isn't a simple algorithm for pain management. There are multiple different best practices and multiple different standards of care and different protocols that we can all utilize depending on what's going on. But there isn't one simple algorithm. You have to custom tailor your treatment. Now, whether that's with medications or with therapy or the combination of a multidisciplinary treatment plan, or even with if it's with ketamine infusions, right? There isn't one protocol. It has to be custom tailored. So that's point number one. And that takes time, by the way. Okay, and this is one of the biggest challenges as we move forward in this new healthcare market where it's all controlled by insurance companies and massive hospital organizations and healthcare organizations that focus on RVUs and they focus on how much revenue you're generating and how many patients you can see per hour. It doesn't leave much time for creative thought or custom tailoring or coordination of care. But please, let that be one of your philosophies of practice management. And if you don't have the time to custom tailor, at least refer that patient out to someone who maybe does have that time to custom tailor. The second thing, and this is something that has to come from within, you have to care, you have to have compassion, you have to truly have this sort of inner burning desire to really see success in that patient. You know, failure in that patient has to affect you deeply. It has to feel like one of your kids failed, or maybe you failed a test or something like that. Really care about that patient, care about that patient's outcome. Simple positive thought does emanate and it does resonate and the patient feels it. And if they feel like you actually care about them and that you're actually hopeful for them and that you actually have a plan that's been somewhat customized for their care, I mean, immediately the patient's going to feel like, hey, there's hope. Like, we might actually beat this horrible thing, you know, the CRPS, or even chronic pain. I mean, chronic pain is just as horrible in terms of its outcomes. When we talk about failed treatments, when we talk about suicide, okay, suicide because patients did not get the treatment that they need. I mean, the numbers are staggering. The numbers are staggering. The patients that have killed themselves because of untreated pain of any kind, whether it's mental or physical pain, absolutely shatters the amount of patients who have died from prescription opioids. And let that thought resonate, because what that means is if we can offer them custom tailored treatments and we actually care about them and we give them hope and we are a team with that patient, your success rates are going to increase, the patients are going to thrive and they're going to do better and they're going to want to be part of that team and want to be part of that success story. And again, if you're part of a system or that doesn't allow that, or this simply isn't a philosophy that makes sense for you, you know, at least do the patient some justice and find someone who can provide those services. It's the best thing to do for your patients. And ultimately, one way or the other, you're going to sleep better at night. You're going to know, okay, when you're 70, 75 years old and you look back at your life, the one thing that you're going to be left with is, did I make a difference in this world? Did that needle change even a little? Did I leave my mark in this world, or are you just going to be another person who just ate a bunch of food but didn't leave any positive legacy? Please be that person who leaves a positive legacy. And I think if you do, you'll be satisfied with yourself, but more importantly, the patients that you see. You're going to change their lives. You're going to change their families' lives. And there's nothing more important as a human being than to be able to leave that happiness behind as part of your legacy. So I leave you with that. Thank you so much for watching. I hope that this was educational and informative. And if you have any further questions, please feel free to reach out to the RSDSA.